Okay, still going. I gotta get the code from the YouTube channel and go to my Wayne webpage of Neurosurgical TV and put it there. And then it'll be live on the front page of Neurosurgical TV also. I guess it does take more than a minute. And I have about 50 channels of what's up that I immediately post on. And you won't see
Okay.
evidence of that in, okay, we're all set there. Okay. Okay. You had a question, Sarath?
No, yeah.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from beautiful Miami Beach here in the background. We have another episode of the Sri Lanka Neurosurgery Grand Rounds, which we've done for quite a while, Sarath. It's run and organized by Sarath Munasinghe, a Sri Lanka neurosurgeon who I think he has an interest mostly in spine, but I think he does it all really in Sri Lanka. And he has a guest, and he's going to introduce and run the show. Good day, Sarath.
Thank you, John. Good morning, good afternoon, good night, wherever you are. So welcome to another episode of Sri Lanka Neurosurgery Grand Rounds. Today, we have the privilege of having another a neurosurgeon, popular neurosurgeon, very good experienced neurosurgeon from India, Mumbai. He's from New Delhi, Dr. Sachin Broka. He's a professor in neurosurgery. And we are very grateful to Sachin for accepting the invitation and coming here and with the presentation. So today we are discussing about a very important and very complex topic. So we welcome Dr. Sachin Broka to Neurosurgery Grand Rounds. Thank you, Sachin, for accepting our invitation and getting on board. So as we regularly do, so I'm going to introduce the topic, and then Sachin will go to his presentation. So let me share my screen first. I hope I'm visible and audible.
Yeah, perfect.
Right. So as I said, the topic today is complex craniovertebral junction and cervical OPLL surgery. So we'll mainly be focusing on the craniovertebral junction and the cervical OPLL surgery. Mainly, we are talking about the complication avoidance and management. So as I mentioned before, as I introduced Sachin, if I'm correct, he's our honored guest speaker today. He's a professor in neurosurgery in All India Institute of Medical Sciences. We all know AIMS. It's a very famous, a well-recognized neurosurgical center in New Delhi, India. So this is our topic. So we are talking about the complication avoidance and management in complex craniovertebral junction surgery. So as neurosurgeons and spine surgeons, sometimes orthopedic surgeons, we know the posterior craniocervical junction is commonly exposed for various pathologies. And we know the anatomy is quite complex. And there are vital regions and structures which are really very important, provided by the posterior bony anatomy and the ligaments, as well as the nerves, the spinal cord, and the blood vessels. So these are the indications for occipital craniocervical junction exposures. So I'm not going into details. So we all know about this: Chiari malformation, atlantoaxial instability, basal invagination. So when we are doing patient selection and preoperative counseling, it's very, very important to consider the risk versus benefit ratio before operating in this region. So I think one should have a frank discussion on the complications with the patient. So we should educate the patient regarding the risk of injury to the spinal cord, the brainstem, and the nerve roots, and also the risk of injury to the vertebral artery, and also the restriction of neck motion, especially the rotation as well as the flexion extension, and also the postoperative occipital neuralgia in certain cases. So we know the restriction of neck rotation in Moine ossifusion, and we need to understand that we need to educate the patient that it is going to be a life-altering operation, which is irreversible. So sometimes it could be career-altering, sometimes it could be a career-ending in some patients. So that one we need to understand, and we need to convince the patient that it may be the future, it may be his future in most of the time. So we need to talk about the operative approach and the patient positioning. So these are the areas where we can avoid the complications, where the complications take place. So as we know, positioning is imperative, very, very important when we are talking about craniovertebral junction surgery, either occipitocervical fixation or C1, C2 fixation. Because if you fix the patient, if you do a fusion in rotation or in abnormal flexion or extension, we know the whole life of the patient is going to be affected. So as we know, few tips. If the fusion is to be performed, we always try to keep the patient's head in neutral position. But we know we want some kind of a flexion in occipitocervical junction. But if we start in a position where we flex the neck, so you can do the screw insertion, but when it comes to placing the rods, then you have to keep the patient's head in neutral position. And also at the same time, we need to be aware of the pressure points. So we need to be aware that the chin is free from compression and the nose is free from compression and the eyes are free from compression. So we all know that this being checked regularly by the anesthetist. And also we need to understand that if we are doing a C1, C2 fusion, the neutral position should be maintained in the axial plane to prevent a fixation with a rotatory component, as we said. And also, if we are doing occipitocervical fusion, it should be neutral in both the axial as well as the sagittal planes. So the patient is not going to have complications during when he's looking forward and walking. And also sometimes patient can have difficulty in swallowing if we fix them in the wrong position. So especially when we do the rods, we have to make sure that the head is in the neutral position. So this is the anatomy of the area we are talking about. So we all know that it's tricky with the vertebral artery, the dura at the foramen magnum, and the nerve roots, so etc., etc. So what about soft tissue dissection? So avoiding complications during soft tissue dissection. So again, before we start the surgery, I forgot to mention that first of all, we need to decide what type of a surgery is indicated. So as we mentioned, so we're talking about the craniocervical junctional area. So we need to identify the anatomy, the pathology, and then we decide the ideal procedure for the patient. And then we decide on the type of surgery depending on the surgeon's experience as well as the patient status, considering all these the components. And then when we operate, as we said, so these are the steps. So intraoperative imaging is critical, identifying the exact location to avoid wrong level surgery. And remember, when you make the skin incision, make an incision only as large as necessary, especially when we dissect the muscles off from C2 and C7. Think about postoperative kyphosis, especially if you are not doing a fixation. And be careful when you use monopolar cautery, because inadvertent durotomy is not uncommon in this area. Right, and also when we do the bone exposure in the C1 posterior, we have to be very careful, especially along the superior border. So we prefer blunt dissection with the pin field number 4 to the use of monopolar artery, especially close to the vertebral artery. As we know, it is safe to dissect 1.5 centimeters approximately from the midline in the posterior arch of C1. And also we have to make sure, we have to be very careful when we do lateral dissection on C2 where the vertebral artery can be injured, especially in elderly people where it is tortuous and it directly lies dorsal to the pars. Right. And as we know, if you are doing C1, C2 surgery, this is not very uncommon. Venous plexus bleeding. So we use gel form and thrombin commonly and compression. And remember, subperiosteal dissection can minimize hemorrhage. Alternatively, you can identify the plexus at the beginning and you can cauterize it with bipolar as well. And if it is uncontrollable bleeding, you can pack with hemostatic agents, and also always to buy some time, you can go to the contralateral side and do the dissection and then come back to the previous site. Right. So C2 nerve root, again, it's controversial whether to take the C2 nerve root or not, but in my opinion, I feel it's always better. It's always advisable to avoid taking the C2 nerve root and to preserve it as much as possible. So what I do is retract it caudally and then identify the facet. And if we need to sacrifice the C2 nerve root, we usually do proximal to the dorsal root ganglion to prevent postoperative occipital neuralgia. But the opinions differ. So some says the removal of the C2 nerve root facilitates the easy access to the C1, C2 joint space. So we can do a good decortication and we can do packing of the graft material into the joint. Right. And what about the vertebral artery? So it's the most one of the most important aspects when you talk about craniovertebral junction surgery. Vertebral artery anatomy anomalies are not that uncommon. So as we know, it's dominant in approximately 60% of the population, the left side, and it's vulnerable to injury during dissection in several locations. One is laterally above the C1 posterior arch, and also during the lateral dissection at the C1, C2 facet joint. So one has to be very careful, very cognizant at these points. So there's a warning sign for the surgeon when there is venous ooze from the perivertebral venous plexus, so we know it is close to the artery. So we have to always think about the preoperative imaging. So that's why we need preoperative planning and preoperative investigations to avoid vertebral artery injuries and to identify the anomalies or the abnormal causes. So we need a CT to evaluate the bony anatomy thoroughly. So there are variations like ponticus, ponticulus, ponticus, and the neuropedicles. And we always try to do a preoperative CT angio. In my setting, it's not always feasible, but I try in almost all the cases to exclude the high riding vertebral artery or the other vertebral artery anomalies. So there are 4 anomalies that we know of the vertebral artery. These are the anomalies. I'm not going into details. So you can see persistent first intersegmental artery or the fenestrated vertebral artery or C2 origin of the pica or recurrent branches of the vertebral artery. So we have seen these anomalies during our career. So a few words about high riding vertebral artery. So as we know, we can damage the vertebral artery if we are placing a C2 pass through with a trajectory that is too caudal or too lateral. So especially when we are doing a transarticular screw, we need to check whether there is a high riding vertebral artery which can damage the vertebral artery. And also in that case, if we are using a pass screw, if we are going for a pass screw, it has to be a short pass screw. For example, around 14 to 16 millimeter in length. So the screw tip will stop short of the vertebral artery groove at C2 without damaging it. So I think everyone knows what a high riding vertebral artery is. So I'm not going into the details. So this is an image of high riding vertebral artery. So you can get an idea with the preoperative imaging. So another word about narrow pedicles. So narrow pedicles we all have encountered, considered as less than 4 millimeter pedicle width. So that's why we need to look at the preoperative axial CT scans, especially in C2. And we have to remember that narrow pedicles most of the time associated with the high riding vertebral artery. So we cannot use a transarticular screw in this case, and we cannot use pedicle screws. In that case, either we had to go for a pass screw or a laminar screw. Again, an image of the bilateral narrow pedicles and high riding vertebral artery. Right. So bony anomalies, ponticulus ponticus, we all know what it is. So the importance of it is failure to recognize of this anomaly can lead to vertebral artery injury during C1 lateral mass screw placement. So it can be mistaken for a broad posterior arch, and so it can lead to inadvertently high placement of the posterior arch screw with resulting in injury to the vertebral artery. So sometimes if the ponticulus is wide or accompanied with the deep vertebral artery groove, it can be removed before screw insertion. So this is the ponticulus ponticus here. And so what are we going to do if there is a vertebral artery injury? So if the vertebral artery is injured during surgery, first of all, we need to inform the anesthetist that there is a vertebral artery injury. So at the same time, we try to achieve the local hemostasis, and then we need to get the immediate follow the steps to prevent vertebral basilar ischemia, and also to prevent future thromboembolic complications. So if we hit the vertebral artery during a screw placement, so placing a screw generally provides the hemostasis. Usually what we do is we insert a shorter screw than intended, that which usually stops the bleeding. And at the same time, we need to remember that if we damage the vertebral artery unilaterally, we are not going to place another screw in the contralateral screw. And in that case, so either we have to go for unilateral fusion combined with wire fixation with wires like Brooks or Galley fusion, or sometimes a halo. So it's always better to get the help from a vascular surgeon and post-op endovascular procedures as well. And again, another word about internal carotid artery injury, which can rarely happen when you put screws in this area. So usually it happens with a C1 screw. If you try to insert a bicortical C1 lateral mass screw or a posterior screw or a transarticular screw, it can happen. That is because the distance between the posterior margin of the ICA and the anterior cortex is very narrow, less than 4 millimeters. So the best way to prevent it is to use a unicortical screw fixation and use a more medial angulation, because the ICA is usually located in a lateral position. All right. Spinal cord injury. We know spinal cord injury can occur during this surgery, but we know it's rare because it's the chances are less of a malposition screw during in this region, because we know C1 lateral mass is a wide lateral mass and the medial cortex of C2 is thick, and also the spinal cord in this area is very capacious. So it has less chance of damaging the cord, even though there is a medial breach in C1 and C2. And we also need to remember the push down force when we do the C1 screw insertion. That is not good, especially when there is cord compression preoperatively. Occipital neuralgia, we talked about it. So We'll get Sachin's opinion as we go on. And also the last but not least, atlanto-occipital joint violation by C1 screws. We have seen it has happened to me. So more superior trajectory of C1 screws can go into the atlanto-occipital joint and cause postoperative pain, sometimes sometimes having to reoperate. So the trajectory directed to a point between the 20% and 40% aspects of the anterior arch of the atlas in the lateral fluoroscopy is considered the safe zone. So this is the safe zone for the C1 lateral mass screw. And always, and at the same time, we need to remember the starting point for the C1 screw should not be too medial. If we are too medial, then it will decrease the amount of space available in the safe zone. Right. So these are the entry points of the screws. C1 lateral mass screw. This is for the pedicle screw. This is for the pass screw or the transarticular pass, and as well as the transarticular is more of the same, and the intralaminar or the translaminar screw. So that is all for the introduction. So I'm having few cases, so we'll talk about this later. So let's invite Sachin for his presentation. So we'll go ahead with Sachin's presentation.
Yeah, thank you, Surat, for a nice introduction and a good anatomical overview of the cervical spine and CV junction. Cervical spine and craniovertebral junction are complex problems to treat, we all know, and the margin of error is quite low, because if you go wrong, the patient can develop life-threatening complications. So I will take you people through the cervical spine surgery, the cervical OPLL first, then the ACDF, and then the craniovertebral junction surgeries. And some are my own complications, so I can tell you how I manage them. And some are tips to avoid complications. It's said that complications are a great teacher, and one should avoid complication rather than managing the complication. So we all learn from our mistakes, and it is also good to learn from others' mistake and avoid the same mistakes, so that the patient outcome is optimized. So thank you very much for the opportunity. I'll now would like to share my screen. Yeah, is it visible, and
Yes,
am I clearly
perfect.
audible?
Yes.
Yes, perfect
Yes.
video and perfect audio.
Okay, good. So I have no disclosures. Let us start straight away with this case. A 45-year-old male, a complaint of cervical spondylotic myelopathy, spasticity, weakness, with a MJOA score of 12. And this is his MRI, which showing an anterior compression at C5, C6 level, and along with a cord signal change. So there is OPLL on CT, which will come in the subsequent picture. We all know that this K line is usually determines your approach, whether you have to do anterior or posterior. If your spine is lordotic or straight, you will prefer a posterior approach, and if it's a kyphotic spine, then you will do an anterior approach. So in this case, it was probably a kyphotic spine at a focal kyphosis, I would say, and we thought that doing a posterior approach won't be a good choice in this, and the patient may not improve. So a direct anterior decompression was planned in this case. So this is his CT. There is a focal as well as segmental OPLL in this case at C5, C6 level. And as you can see, cauliflower type appearance on the axial CT scan, and which is important. And the cord is actually draped over this OPLL. So you have to be extremely careful of damaging the cord. At times, you may also have the dural ossification in such cases, which increases the chances of dural tear, anterior dural tear. So this is what we did, the C5, C6 anterior cervical corpectomy, the standard anterior cervical exposure, defining the disc above and below, and then taking out the disc. We try to preserve this bone for subsequent grafting within the cage, and gradually drilling the bone, initially with a cutting drill, then with a diamond drill posterior at the posterior surface. So as you can see, I am drilling thinning the OPLL by gradual drilling with a diamond drill. With irrigation, the assistant is doing irrigation. So this is what is being done. So before I could realize, there is already a dural tear. So can you see just below that suction? So fortunately, there is no CSF leak. The arachnoid is intact, but there is a dural tear. So now you are worried that progressing further can risk CSF leak. So I went to the other area of the OPLL and tried thinning it out, tried to find a plane between the OPLL and the dura. So gradual thinning out of the bone, then using a flat dissector to make a plane between the sheet of OPLL and the dura mater. So as the PLL is deficient laterally, trying to find a plane laterally, gradual, step-by-step delineating the PLL and trying to divide it. So a lot of patience, and I left that area where there was a dural tear for the last. So again, gradual trying to find a plane, gradual thinning. And with patience, I could elevate the entire sheet of OPLL without further damaging the dura or causing any CSF leak. As you can see, it's a completely well decompressed. This is the last bit, and this is the sheet of OPLL, which is being elevated from the thecal sac. So this is the decompressed cord. There is still no CSF leak, but there is a dural tear, which, since there is no CSF arachnoid tear, we just put some fat and then supplemented it with a tissue glue, then did the cage and plate fixation the standard way, and the patient had a good outcome. So this case highlights how critical is drilling in spine, and especially in OPLL cases. And I will come to that tips a little while later. So the incidence of OPLL, the dural tear in OPLL surgery is much less common, but in cervical spine surgery is much less common compared to the thoracolumbar surgeries. But it depends on the cases. So AC anterior only OPLL surgery has the highest chances of up to 6% and dural tear compared to a single level or ACDF or an AC corpectomy. And again, revision surgery has high risk, and OPLL, the relative risk is almost 19 times. So though, and it is frequently observed in patients in which the canal occupancy ratio by the OPLL is more than 50%. And patients with dural ossification, the tram track sign, what they say on CT, as you can see in this CT image. So there is double layer sign that is a very characteristic of dural ossification in OPL. So it's always has to be, you have to carefully see your preoperative imaging to check whether the dura is ossified. Then the risk will be much higher than the cases in which there is no dural ossification. What you can do if in this case, I could actually took out with some efforts the entire sheet of the ossified PLL. However, at times, if it is very much stuck or there is dural ossification, then you can actually isolate it from all sides, thin it out, and keep it floating attached to the dura. So this is called as the anterior floating technique, and it is a free floating mass of the PLL over the dura, which is no longer is compressing, it is just floating with the dura. So that few isolated island of this free floating bones can be an option in case there is if you are very much worried about the dural tear. If indeed it happens, then what I showed you is a simple way, because there was no CSF leak as such, just a dural tear without any arachnoid tear. So we could manage with just fat and glue. However, primary repair is frequently not possible there because it is very much thinned out, and it is difficult to put sutures at depth in that location. So if you feel that there is a florid CSF leak and you have supplemented with fat and glue or fascia and glue, then it may be a good choice to put a lumbar CSF drain for 4 or 5 days and give some bed rest and head and elevation. And most of the time, this is taken care of. So primary repair, though best, is frequently not possible. Lumbar CSF drainage gives you the fistula some time to heal, and but the care should be taken that lumbar CSF drainage can get complicated by meningitis. So a good precaution has to be taken. And this, most of the patient, almost 80 to 88% patient improve with this treatment and doesn't require any further intervention. So to take home message about this OPLL with anterior approach, posterior approach is a bit straightforward because you're just doing either a laminectomy or a laminoplasty, and there is means the risks are lesser compared to the anterior OPLL surgery. So the intradural tear is fortunately rare. However, there are higher chances with OPLL cases. Primary repair is frequently not possible, and the most pragmatic solution is fat fascia glue supplemented by a few days of lumbar CSF draining. Okay, so I was coming to this tips of drilling in spine. So what should be done, how it should be drilled is you have to hold the drill like a pen or a pen brush, and rather than doing a focal drilling at one point, you have to do gradual side-to-side drilling and use a copious irrigation so that there is no thermal damage to the cord. I'll show you a video in how to do that. The other thing is you have to judiciously use the cutting drill and the diamond drill depending on the location. So like in the initial part of corpectomy, you can use a cutting drill, and in the posterior aspect closer to the dura, a diamond drill is more controlled, and it is also causes some amount of hemostasis, so the cancellous bony bleeding is taken care of. However, the problem with diamond drill is it generates a lot of heat, so you have to keep on irrigating it well. So I'll just come with a video on how to do drilling. So is it visible? In this video?
Let's see here. Yes, it is.
Yeah, we'll discuss the tips for drilling in spine. After the exposure of the cranial and the caudal lamina, you should use a cutting burr or like pen or a paintbrush and do side to side move. This is a lumbar spine video, but the it remains the technique remains the same. So the whatever is said is applicable even to any portion of the spine. Gradually thin out the lamina layer by layer, rather than doing a focal drilling at one point. Drilling should be supplemented with some amount of irrigation to avoid thermal damage to the underlying structures. Once you drill layer by layer, once a thin shell of bone is left, you can see the flavum in picture. Effort should be made to find the plane between the flavum and the thecal sac, and this flavum is then excised using upcut. Thank you for your kind attention. So going ahead, this is what was how to drill in spine. Then coming to a more common thing which we usually do, the ACDF rather than an OP. Yeah, Surat, I'm visible, na?
Yeah,
Yes.
visible. Yeah, visible and
Yeah.
audible. Yes.
Yeah. So the more common thing we do is the ACDF rather than an anterior only OPL surgery. So ACDF tips is important to expose the uncinate process bilaterally, because that is the landmark for an adequate decompression. So uncinate process, we all know, are the processes which are from the upper surface of the vertebra, and the where it turns upwards, the end plates turn upward, are the uncinate process. They have to be exposed so to have an adequate decompression on bilateral roots. One important point is, at times we are carried away by the disc herniation and do not address the osteophyte. So this was an interesting case operated recently, around a week back. So the patient has myelopathy, and on contrast scan, there is a contrast enhancement at the C3, C4 level, and some amount of edema in the T2 scan signal change. So this was misdiagnosed at a peripheral center and sent to us as a case of intramedullary tumor. However, this pancake-like contrast enhancement is very typical of degenerative cases, and even degenerative disc herniation can have this sort of contrast enhancement. So one should always be knowing this fact that this can be degenerative and not approach it like a tumor. So because of repeated micromotion, by the disc and the osteophyte is causing the damage to the cord, and that's why at times it can enhance as well. So in this case, my point for ACDF, this is a learning point that you should keep in mind. More important point is that addressing this osteophyte. So removing disc and removing PLL is important aspect, but removing this osteophyte, which is actually hidden, is, as you can see in this X-ray, there is a hook after doing the removing the osteophyte using upcuts. We are putting a hook so that to ensure that the thecal sac is adequately decompressed. So if you do not remove this osteophyte, then the patient won't improve, or he has the risk of repeated trauma because of this osteophyte. So you should always remember to remove this osteophyte, the posterior osteophyte, and then put the graft. So for removing this osteophyte, again, you should not put big upcuts within the thecal sac, because there is already a very narrow space because of myelopathy, and you should put maximum 1 or 2 mm upcut to remove this bone, or use a drill to thin this out and use the smallest upcut possible to remove this bone. Otherwise, if your foot plate of the upcut is bigger, if you are using maybe a 3 mm or 4 mm upcut, that 3 mm is compromising the canal and further damaging the already compromised cord. So that should be kept in mind. So I'll show you how this affected one case. Yeah. So this is a case which was operated for cervical spondylotic myelopathy outside, and the patient didn't improve and then came to us. And you can see that what the surgeon didn't address was the osteophyte. So this was his preoperative scan, and this was the postoperative scan. So the signal change is same. And if you carefully see the CT, so these osteophytes are not addressed. This osteophyte was not addressed, and only the anterior portion, the disc was removed and the graft and plate was put. So this is the point that the osteophyte, if it would have been addressed, it would have been easy, and the patient would have improved. So revision ACDF is another challenge, because you are going in that plane. It's difficult. There are adhesions, the plate. You have to be extremely careful not to damage the neurovascular structures. And even after this, there are because there is partial fusion of the cage with the bone above and below. So at times removing that cage is also difficult. So always be careful. You'll see in the next few seconds how difficult it is to remove that partially fused cage. One option was to go posterior as well, but we thought that since this osteophyte is the culprit, we'll go ahead anteriorly and do a thorough job. So after this plate is so this is a sort of tissue which is formed over the cage. And this is the two cages are there. So the cage is there is pseudoarthrosis, but the bone graft within it has partially fused with the vertebra above and below. So it is not getting removed. To remove the peak cages, we had to do a corpectomy and then remove it. So that is how difficult it is. So a thorough first job is more important. And you can see that the cage is getting removed and the hydroxyapatite inside is such a flimsy fusion. So one should always be not carried away by this hydroxyapatite, and it's better to use an autologous bone graft, which is still the gold standard for anterior cervical fusion and gives a good long-term fusion rates with minimum complication. So this is how it is done. So coming to the craniovertebral junction now. So a lot of the anatomy has been covered by Dr. Surat very nicely. So
yeah, Sachin, can I interrupt you for a moment?
Yeah.
Regarding that previous case, now if you go back to the previous slide, yeah. Can you go back to the previous slide? Yeah, and then this one. Yeah, so you can see the code changes. It's spanning over from starting from C3 to C5. So in that case, as you said correctly, I mean, if I were to do this case, so I would go posteriorly and do a laminectomy from C3 to C5 rather than going anteriorly. So my question is why, what made you to go anteriorly rather than posteriorly in that case?
So obviously, there can be, this is a case in which you can do both anterior or posterior approach.
Yeah.
What I haven't put all the cuts, but when you see the axial cut at each level, the predominant compression was at C3, C4 level. The signal changes can actually extend beyond the level of compression as well. So as it happens in something like a central cord syndrome, in which because of repeated motion. So, but the axial cut was specifically showing more compression by the disc osteophyte complex. Even the lateral parasagittal cuts were more suggestive of a single level compression. And this was a young patient, so we thought to do an anterior approach.
Okay, thank you.
Yeah. So coming to the CV junction anomalies, we all know that they come in all shapes and sizes, from children to adults, from congenital, developmental. Then each CV junction is different. Some have occipitalized atlas, some have just reducible AD, some have reducible AD, some have platybasia. So all these three cases shown here are a spectrum of CV junction anomalies. And this is one case, a 20-year-old male, a progressive spastic quadriparesis, sensory loss below C2. And as you can see on the X-ray, there is irreducible atlantoaxial dislocation. And this is the MRI, which is showing a basilar invagination with anterior compression by the invaginating odontoid process. And if you do the CT scan, it is showing an atlantodental interval of 8 mm and a basilar invagination of 1 centimeter. The C1 is not occipitalized. The joint orientation is horizontal or only partially oblique. This is the joint orientation we see if you are planning a posterior only approach. And both the joints are pretty horizontal. So if you had to go by this algorithm by Menezes, which was in the 90s, was the workhorse for craniovertebral junction surgery, then you will realize that if there are irreducible atlantoaxial dislocation, if the compression is ventral, then the suggested modality was doing a transferal resection of this odontoid process and doing a posterior fixation and occipitocervical fusion in most cases. However, a lot has changed over years. So reducible AD is a bit straightforward. You can do a selective C1, C2 fixation by various methods. There is Goel-Harms technique, there is C1, C2 transarticular screw, which Surat said. But irreducible AD is a bit complex and obviously controversial as well, whether to go anterior, posterior, only posterior, etc. So this is Dr. Goel's landmark paper in 1994, when he said that the problem is not in the odontoid process, it is in the joints between the C1, C2 joints. And he asked us, everyone and the world, to see at the C1, C2 joints rather than the odontoid process and decompression. And that is his biggest contribution to this CV junction surgery. And there are various methods, various ways the CV junction present. And as per Dr. Goel, that there is no fixed AD, there is no irreducible AD. Everything can be reduced from the posterior aspect by opening the joint. This is what Dr. Goyal says, and he has many papers on this. There is a concept of facetal malalignment, anteriorly displaced, posteriorly displaced. Then there is a concept of central craniocervical instability. So seminal work by Dr. Goyal on this. Then there is another technique which has come from my institute, a distraction, compression, extension, and reduction technique. So what they do is put the spacer in the C1, C2 joint. So what happens is, because of that, the BI gets reduced, the BI, the odontoid tip comes down. And then by using a compression between occiput and the C2, they cause extension motion, which reduces the atlantexual dislocation. So this is a patented technique by the name of DCER, described by my teacher, Dr. Sharat Chandra. And it's a very good technique. So what is done is, because of the spacer, that the BI is reduced, and by compression, the AAD and the residual BI is further reduced. So this can be done in an occipitalized atlas or even in a non-occipitalized atlas. And this is how it is done. I'll show you a video soon. Then there is a concept of sagittal inclination and the joint inclination. So what is meant by that? So as I was telling in the first case, that the joint were horizontal or favorable. So this is a sagittal inclination of less than 100 degrees. These joints are favorable. They are easier to open from a posterior aspect. As it goes more obtuse, then progressively it becomes difficult to open them. So this is a more obtuse joint, maybe a 130 degree. And then to put a spacer in that joint, you may have to drill a part of the C1 lateral mass and the C2 and make a wedge-shaped space to put the spacer. And in patients who have almost vertical joint like this opening the joint becomes further more difficult. So then based on this, he has proposed 3 types of surgery: a DCER or a joint remodeling, as I said, that drill that joint, make it flat, and an extra-articular DCER. So these are increasingly complex level of surgeries and increasingly complex problem. So this is a simple sagittal inclination of 100 degree, not very obtuse angle. You can open this, and it is done by the same technique. And you can see that the ADI has reduced from 8 mm to 1 mm, and there is no BI. The BI has also reduced. So the height of the spacer is actually is usually the height of the BI, which is to be corrected. Then another case, a 7 mm ADI, 9 mm BI. The joint morphology is a bit oblique, but you can remodel this joint, drill a bit and put spacer there. And as you can see, this is corrected by a simple posterior technique rather than doing a transforal surgery. So there are many such cases which can be managed. Obviously, the joint orientation needs to be favorable, and this you have to see on coronal as well as on the sagittal plane. And these are various cases done by this technique, putting spacers and putting screws in the C1, C2. At times, if this C2, the vertebral artery is anomalous, then you can use a C3 anchor, something like that. And good fusion, good long-term outcome. Then the problem happens with progressively higher sagittal inclination, and the sagittal inclination in some cases is almost 180 degree. The joint is actually vertical. It's very difficult to open this joint, or it is so then there is a concept of pseudo joint also, but opening this true joint is progressively very difficult. Then there are cases like this, the pediatric cases, good no bone stock, vertical joints. So all these are complex CV junction anomalies. This is another case. As you can see, So this was what was done outside. So they couldn't reduce it because the joint couldn't be opened. They just fixed from the back. So the point of showing this scan is how difficult it is, that it is not always possible. So for such cases, then there is still some role of transoral odontoidectomy or anterior decompression, and I'll show you some of the indications of transoral odontoidectomy. So you all know that a CV junction tuberculosis is very prevalent in Indian subcontinent, with a big vertebral abscess causing anterior compression are still managed by a transoral decompression. Tumors like myelomas, ABCs, again has to be done transorally. Rheumatoid arthritis with pannus, which is the cause of compression, are still managed by transorally. Then there are some cases like old malunited fracture, in which the C2 is fused with the anterior aspect of the C1. So without doing an anterior release and anterior decompression, it is not possible to reduce just by opening the joint, because the anterior part is also fused. So there are still some indications left of transoral odontoidectomy, and this is how it is to be done. Then there are some cases which are showed a severe amount of CV junction kyphosis, as you can see in this case, in which you cannot make out where the severe amount of the cord is stretched like a rubber band over this kyphosis, and the joint orientation and everything is quite very unfavorable. And the patient is also very compromised because of this compression. He has a single breath count of 10 seconds, and he's using his accessory muscles. So any manipulation in this area again then becomes tricky. So such cases, maybe then it may be safer to do a transoral decompression and do a posterior fixation. So this was what precisely was done in this case. Even a transoral is difficult in such cases. So there are some subset which will still require transoral surgery. Then there are pediatric and syndromic CV junction anomalies, and they come with a different challenge. So as you can see, this is small bones, thin lateral mass, so no poor bone stock, and how are you going to fix them? But they have come with myelopathy and an AAD, so you have to treat them. So then there are syndromes like achondroplasia, MORQ, mucopolysaccharidosis. Lot of syndromes have this problem, and it has to be thought of how to do such cases. The challenges are again very thin lateral mass, partially cartilaginous bones and posterior arch. Screw placement is extremely critical, and many a time if there is breakage or blowout, screw revision again is not possible. So in such cases, you should always be conversant with the sublaminar wires, sublaminar cables, and rods as a salvage option. If you cannot put screws, then you have to be ready with the sublaminar wires, and that gives a good fixation. Some similar something like an hybrid construct, whenever you can put a screw in one and a hook in the upper part. So all these things should be in your armamentarium whenever you are doing pediatric and syndromic cases. And at times, if there is screw breakage and there is no second chance in such cases. Everything is thinned out. So the points which Surat told, the lamina is also thin, the pars is also thin, the lateral mass you cannot use, or it has broken out. So effectively, there is no salvage other than a sublaminar wire. And this technique you should learn. And there are now titanium cables to do sublaminar wiring, and then it's MRI compatible as well. If possible, if the lamina is big enough, then you can use a C2 translaminar. But in pediatric and syndromic, especially, it's very, very difficult. So there are, again, I'll show one of the cases. This is a progressive kyphotic deformity of the spine. The child is, I think, 9-year-old. And again, as you can see, he has a very thin lateral masses. We put him on traction, tried to correct the deformity a bit, did an anterior decompression, and posteriorly we couldn't do any screw. So we will put just a sublaminar wire as a anchor and put a lot of bone graft, and it all fused. The patient improved. This is the anterior corpectomy with a peak cage with a bone graft inside and a plate. So the screw is put in the C2 and I think the C5, so 2-level corpectomy and a posterior sublaminar wiring. So this salvage option should always be ready. So I'll show you the video after this conclusion. So they are complex problems to treat, and the BI understanding, the basilar invagination understanding, has undergone a sea change in the last 2 decades. So more and more posterior approach, more and more opening the joints rather than doing a transferal decompression. The trend is more towards posterior only approach with C1, C2 joint manipulation, bone graft or spacer placement, and single stage reduction of BI as well as AD, as I've shown you. But you have to be cautious. Learning curve is there, anomalous vertebral artery, vertebral venous plexus, everything. The more complex the anatomy, more difficult T level is there. And difficult cases are those with vertical joints, as I've shown you, high sagittal inclination, extremely retroflex odontoid. These are all tricky cases, and neuromonitoring is extremely helpful in such cases. Transferal may be needed in some select cases, though the indications have gone down significantly. But you should always be aware of this fact that whatever is working best in your hands is important, because these are all benign problems. So once you treat them well, then the patient can have a good outcome. So I'll show you some of the videos now to how to do a C1, C2 joint exposure, which Dr. Surat told you in theory. We can see some of the videos, the DCR technique, how it is done. And if you need to do a transferal, again, a transferal video as well. And then we can take the questions, okay?
Okay, Sarat.
Yeah. I'll just showing, yeah.
Okay.
So this is the C1, C2. This is the C1 posterior arch, the C2, and we are trying to open the working between the C1, C2 joint area. Regarding the C2 ganglion, again, if you are new to this area, it's better to sacrifice the nerve root. There are not long-term significant complication except for some amount of occipital numbness. So as you can see, there is a vertebral venous plexus, and as you put this microcaesar, it bled. So how to control that is to use a bipolar cautery, and under irrigation, trying to coagulate it, shrink it if it's possible. If it is not, then put gel foam. Gel foam is extremely handy here because it works by mechanical pressure. So we are trying to control this with gradual coagulation. So many people do not attempt C1, C2 and just do OC fusion because they are worried about this vertebral venous plexus. So doing this subperiosteal dissection again is important to follow this parse of the C2, and you will go to the joint. Again, this area is pretty vascular in some congenital cases. So this is the gel foam being put. If there is a lot of bleeding, you just pack it for some time, go to the other joint, and then come back. And always work on the undersurface of the C1 posterior arch, and do not run on the superior surface of C1, because that is where the vertebral artery lies. So you do not have to meddle with the vertebral artery. So always below the C1 posterior arch inferior aspect. And this is what we are trying to clear this area. So I'm probing the joint by the dissector. So this is I'm working over the pars. Then another layer of soft tissue. The vertebral venous plexus has been taken care of. Then you divide it. So it will take some time initially, but as you grow in experience, then it is not very difficult. The ganglion can be sacrificed in initial cases, and if once you get experience, you can then mobilize it. At times, you have to work on this inferior aspect of the C1 posterior arch to make some more space, and even drill a bit of it to accommodate the C1 screw head. So I'll show you in the subsequent video. Again, we are working on the other joint. Follow this pars and you will reach the joint. Do not come from C1 to the joint. It's better to go from the C2 pars to the C1 C2 joint. And you have to do it under a good amount of magnification. And you can see now we are trying to open the joint. The articular cartilage is coming in picture. And you can feel the C1 lateral mass up and the joint between. So this is how it is exposed. Then the next step is to do a DCER, how it is done. So once the joint is, this is the magnified view of the joint exposure in some other case. So we are trying to open this joint. That the C1 lateral mass, and I'm trying to put my periosteal elevator within the joint. And you see that there is a movement between the C1, C2. So it's opening up, and that is what Dr. Goyal says, that once you open the joint, this fix becomes a mobile sort of anomaly. Again, this subperiosteal dissection and trying to reach the joint. Then opening the joint, decorticate, coating it with cautery or some small biopsy forceps, putting the spacer. Once you put the spacer, then since you are doing compression, it is a good idea to remove a bit of foramen magnum rim to give some more space to the CV junction. So we remove around the 1.5 centimeter foramen magnum rim before doing any compression maneuver at the CV junction. Then we put the screws in the C2 pars, and in this case even a C3, because they are high degree of kyphosis here. So we are taking an additional anchor in C3. So this is the C2 pars and the C3 lateral mass. So once these 4 screws are put below, there is a temporary occipital screw in the midline, and you create a stainless steel wire and do compression between this temporary occipital screw and the C2. So if you compress between them by gradual crimping, this will bring the occiput and C2 closer together, and then you fix it in that position. So that will cause, you check on C-arm that it is reduced, and do it under neuromonitoring, that when you are doing compression, there should not be any drop, and then fix it in this position. for a final fixation, and then remove this compression, the temporary occipital screw as well. So this is what is DCR, and I already shown you the post-operative scan, how they look like. Then if you intend to do a transoral odontoidectomy, which again, then this is the uvula and Foley's catheter to retract the uvula. You are putting a suture. This is the anterior approach. We have used the Dingman retractor to expose it, and you put the Foley's through the nose and just pull this out. Now this is the posterior pharyngeal wall in picture, and you can see this is the tongue blade, and you are doing an incision in the posterior pharyngeal wall. Use the pharyngeal retractor to expose this, and by a subperiosteal dissection, as you do in an ACDF sort of thing, remove this longus colli muscle, the posterior pharyngeal muscle, and you are directly over the C1 anterior arch and the C2. So this is the bone through a transoral approach, and always first reach the tip of the odontoid and do not start drilling. So this is what is being done. You have to reach the tip first, remove the C1 anterior arch if it is there. As you can see in this X-ray, this is the tip, and you have to reach there before starting drilling from top to bottom. Do not go from bottom to top, because then the odontoid can become free and it may be difficult to drill it. And you do a good bony decompression. If there is any pannus, soft tissue, try to remove it. There is actually no need to remove all the ligaments. A good bony decompression, and it is not necessary to see the dura. You can even leave a bit of ligaments, and then depending on the X-ray and the intended decompression you need, you can extend it. Also from the tip to bottom and from lateral to lateral, you should be clear that you have decompressed well, and not just in the center part. So even the lateral part should be well decompressed. This is what you can see, that you have completely removed it. And if there is any ledge of bone, you can just with an upcut or a drill, you can remove this last portion. The more important thing is closure, and with good microsurgical technique, it can be done very well, either a single layer or a double layer closure, because it's a mucosa, it heals really well. So just a good closure, as I'll show you in the subsequent part of the video, is important. Then you just use the Vicryl 2.0 or 3.0. Use a scale to glide your knot down, and this is how it is done. And you may put a Riles tube for 4 or 5 days, so to give this this wound some healing time. So this is how the transoral is done, and then you remove this red rubber catheter, and okay. And so one word about the intraoperative neuromonitoring in spine surgery. So it is, if you are doing all this complex surgery, I think it's important you do it with neuromonitoring. And there are, like this cases, the CV junction, which I showed, then a complex cervicodorsal kyphosis, then a chin on chest deformity. All these are very complex deformities, and any manipulation can risk damaging the cord. So obviously, so everything should be done under neuromonitoring. There are various ways, MEP and D wave and triggered EMG, SSEP, all are relevant to spine surgery. but most commonly done are SSAP, MEP. And if you have the facility of D-wave, it's very good, especially in myelopathy cases where the MEP may be difficult to elicit or is unreliable, but if the D-wave is intact, then you can safely do surgery. So in myelopathy, if or in an intramedullary tumor, if you are operating, the MEP may drop, but the D wave will remain intact, and D wave will give you a better chance of long-term good outcome. So to take home is, again, IONM, intraoperative neuromonitoring in spine surgery, is a new technology, and multimodality SSCP, MEP, and D wave is suggested. It increased the safety of surgery. The studies which are for or and for against doing monitoring, but it is really helpful. As per my experience, it may soon become a standard of care. It has become a standard of care in many places, but even in other places, it will soon become a standard of care. Thank you very much for your kind attention. I hope I was able to address some of the technical tips in this my talk. Thank you very much.
Thank you very much, Sachin. It was an excellent presentation, which is very informative, and which is, I mean, I'm very happy with all the, the information you mentioned with the videos and all. It's a fantastic presentation. And so I know it's a vast area to discuss. So it's not easy to discuss all the facts within 60 minutes or 90 minutes. So there are lots of things to discuss on this region of craniovertebral junction as well as OPLL surgery. So very nice to have you again for this webcast. So before we wind up, I just want to show you a few of my cases and on craniovertebral junction surgery. So I'll get your expert opinion as well. So let's have a very brief discussion on this case. This patient, it's a 60-year-old male who presented to us with neurological intact after road traffic accident. And he presented with this CT. And first of all, I need to tell you that I'm working in a periphery, so I don't have a neuromonitoring facilities, so I don't have a neuronavigation facilities. So I do all these surgeries without navigation and without neuromonitoring with very limited resources. So the most problematic is with the the constructs. So we don't have the constructs provided by the government nowadays. So because of so many issues, so the patients has to buy it, which is quite expensive at that time. So you can see there is a C2 odontoid fracture type 2 as well as 2, 3, 4, 4, 5 partial dislocation as well. So this is the MRI. So there is no disc prolapse. So I decided to go posterior in this case. So this is the X-ray, which shows it is unstable. So this is the let me play. This is the CT. This is the axials. And this is what I did. So I did a posterior fixation all the way from C1 to C5. So I have used a limited number of screws because, as I said, I don't have the luxury of having the adequate amount of screws, which is ideal. So this is the post-op CT. Any comments on that, Sachin?
Surat, can you show me the X-ray which you showed pre-op X-ray?
Pre-op, yeah.
So this is probably a type 2 odontoid fracture along with. So there is no dynamic X-ray here.
No, there's no dynamic. Yeah, there was a flexion extension one, but I couldn't find it out. Okay, it was unstable. Yeah,
it was unstable. So one way is to definitely check in type 2 odontoid fracture about this instability by doing a flexion extension or doing an MRI in which there will be a T2 hyperintense signal change in the transverse atlantal ligament. That is an indirect marker of instability. So what you decided to do in this case, as it was unstable, a C1, C2 is a perfectly correct operation. As the patient also had some amount of listhesis at D4, 5, you decided to fix it up to C5. That is also a single posterior approach and addressing all these in one go. That's a good choice. The only concern oblique the counter argument is that obviously he needed a C1, C2 fixation, but he was not very symptomatic for the cervical problem. So that could have been delayed as well. But I can understand that in many of the times the patient didn't then turn up for follow-up. So it's better to address it in the same sitting. You are anyway exposing the C1, C2 area. So it's a well-managed case.
Yeah, thank you, Sachin. Yeah, that's one of the biggest problems we have working in periphery. So most of these patients are unreliable. So most of the time we lose these patients during follow-up. So that is one of the reasons. Right. So yeah. And this is another case of occipitocervical fusion done for rheumatoid arthritis. Patient with severe myelopathy. So as you said, I was also scared to put the C1 screws in the initial stages of my career. So I skipped the C1 and I did the C2, C3 instead of that. So just to show you, again, another oxyfixation, again, skipping the C1. Right. So this is another case I did recently. Again, a patient presented with following a fall, 65 years of age. And you can see there is increased atlantodental interval as well. And this patient was symptomatic, presenting with deteriorating numbness as well as a weakness. So for this patient, he had a fall 10 years back and succumbed this injury, and he was having this chronic severe neck pain as well. So this is his preoperative CT. So again, it was not an easy surgery. You can see the deformity he had from the previously as well. So this is the so I decided to do an ossifixation. I had to do an ossifixation because he had an aberrant vertebral artery on one side, on the right side. So I couldn't insert C1 screw on that side. So we did the ossifixation. Actually, I'm showing this you as a complication. I think you can see what's wrong here. If you see the C1 screw, I think it's going towards the atlanto-occipital joint. So right, so this is a different case. What is your thought on this case? Actually, I couldn't achieve a reduction because this is a chronic, old subluxation. So as you said correctly, spaces would have been a good choice. But I actually I did not open the C1, C2 joint here, and we don't have spaces as well.
So even if no spacers, you can put a bone graft as well. So locally harvested bone graft, opening the joint will give you some amount of mobility, and then jamming it with the bone graft. Many people do not use spacers, but they use bone graft so that the joint gets opened up, and then it gets aligned, and then it gets fused. So that is one option. The other thing which is actually in this case is, along with an AAD, atlantoaxial dislocation, there is a component of AOD as well, a degenerative sort of AOD. So in the sense, if you can see the CT, the preoperative CT, the occiput and the C1 lateral mass are not aligned. It is you check it well, you'll see the video one. Yeah, so this video you'll see. So this alignment between occiput and the C1 lateral mass is also a bit malaligned. So in this case, obviously, rather than doing a selective C1 C2, as you won't address the OC problem, there is a term called as a degenerative AOD, and that is a good choice to use an occiput as an anchor. But if you could have opened the joint, it could have led to better reduction. The problem again in this case is a subaxial kyphosis. So your construct is actually stopping at the apex of the kyphosis, and which is not very physiological in the sense that it should not stop in the middle of the deformity. But this is what the best you could do in that setup. And if it fuses with a adequate bone graft, then it's good.
Thank you, Sachin. As I said, so the patient could not afford, the further construct, so I had to stop with at that level. So he could only afford 4 lateral mass screws. So that is one of the limitations we have when we are working in such conditions. It's very difficult for us as well. So it's not the ideal, but actually his neck pain improved, and fortunately up to now he is not complaining of any occipital pain, although the trajectory of the C1 screw is a bit higher, right? And this is again another case. I just wanted to show you that there is a medial breach during C2 pedicle screw fixation, but that patient did not have any neurological deficit, so I did not want to revise the screw. So that's what we say. So rather than having a lateral breach, even though it's a minimal medial breach without any neurological sequelae, so there is no need to go and revise it. What you said, you agree with that? So if the patient is neurologically intact.
The good thing about CV junction is that the canal is very capacious there, and that can accommodate a bit of medial breach. Obviously, it doesn't look good on CT scan, and So if there is no clinical problem and if it is not a very great medial bridge, then you can leave it. But other than whenever possible, I tend to put pars screws rather than the pedicle screws. Pedicle screws is obviously more biomechanically superior, but pars screws also does a good job because anyway you are taking an additional anchor in C3 in most of these cases, so that load sharing is done well. So then this issue of medial bridge won't happen if you are using more of par screw. But I agree that if it's clinically insignificant, clinically not symptomatic, then you can leave it and hope that it doesn't go to your competitor who says that the screw is malplaced.
Yeah, right. So that patient is absolutely fine. It's a young girl, and she had this burst fracture in C5 as well. So I had to do the anterior procedure as well, as it was unstable. It was after some time. And this is to show you that there was, some kind of rotation. So this is a problem we encountered during positioning. So we had two complications in this case. So this is one case, as you clearly mentioned in your presentation. So this is again an old fracture. So what would your approach for this one, Sachin?
So I think it is not fused. So you can still open it posteriorly. The C1, C2 joint morphology is favorable in this, and it is not a bony union. Even if it is there, it may be a just sort of fibrous union which can get stretched up by opening the joint. So it is still doable from a posterior aspect. But if you are not very convenient opening the C1, C2 joint, then just doing a transoral decompression, doing a posterior fixation is also a good option. But I believe that this is doable from a posterior only approach.
Right, thank you. So he has severe cervical myelopathy and he was actually quadriparetic. So this is what we did. So we did an OC fusion. And patient actually did very well. This is another case where, so actually we forgot to talk about the hardware complication. This is a complication of hardware. So screw breakage as well as this loosening of the screws, which is not very uncommon, especially with some kind of, some sort of hardware that we use. So this is that case. So these are the complications that I have encountered with regard to craniovertebral junction. So I think we had a wonderful webcast today with Dr. Sachin Boka, and I'm very grateful to him. So he had.
Excuse me, Sarath, we have a question before we end.
Yes.
Okay.
Yeah.
Do you see it in the channel, in the chat? Go ahead.
Yeah. So I think I can answer this question.
Yeah, I think he wants to ask you personally for networking reasons.
DCR technique. He's asking about the size of spacer. So
yeah, he wants to ask you directly. Just wait a minute. Okay, Dr. Milan, you can come on now. Go ahead.
Yeah. This is Dr. Sachin Boka, Master Dr. Milan Sanjay. Yeah, very nice presentation regarding DCR technique. Just want to know regarding how do you decide in your clinical practice the size of spacer? And in a very severe cases, if you put a very big size spacer plus compression at occipital C2 junction can really stretch the cervicomedullary junction. So how you decide the size of spacer? That I want to know.
So as I told you that the Wickenham's clavicle canal line which we draw and the BI which is going above that, it is actually the you want to align it as per the clivus canal line. So usually the spacer is of the size of the BI above the Wickenham's clavicle canal line. Most of the time it is around 8 mm, 9 mm, 10 mm, and that's safely tolerated by the cord. If it is bigger than that, then maybe 12 mm, 13 mm, then becomes a bit tricky. But under neuromonitoring, if you're putting a spacer oblique trial before that spacer, you should always check that the highest amount of spacer which is being tolerated by the cord, that only you should use. And bigger the spacer, the more chances of the cord being stretched. I agree with you, but usually 10 mm or 12 mm will be the highest spacer which can be used. And then you may have to accept a lesser correction rather than making an absolutely fine CT scan, but a quadriplegic patient. So that should not be done. So that's why all these cases has to be done under neuromonitoring. Because any amount of distraction there in a compromised cord can be a bit troublesome.
Yeah. One more question, Sachin. Do you do these C1, C2 fixations under navigation, or is it freehand technique?
No. These are all freehand technique. Using navigation in cervical spine is again a bit tricky, in the sense there is already a lot of motion in the cervical spine. So unless and the landmarks are pretty straightforward. The lateral mass is pretty easy. The C1 has a good bone stock, the lateral mass. If you are following the pars and going to the joint, you can palpate the medial and the lateral border. So you exactly know where is the bone stock and where to enter. So I do not think that it is needed. But if you have the facility, then you can do that. But you should always factor in the micro motion which happens in the cervical spine, especially in the pediatric cases. If you press the spine, the entire spine goes a bit down, something like that. And then you have to put a reference frame as well to have anchor. So it is doable without a navigation. A simple C-arm will do with some practice.
Right. Thank you very much. So again, very grateful to Professor Sachin Boka to have presented on Sri Lanka neurosurgical grand rounds today. So it was a very comprehensive presentation. So we really look forward to have him again on another day to discuss on a different topic, maybe a cranial surgery. So thank you very much, Sachin, for your time, for your valuable time. And so it concludes our webcast today. So before we wind up, just to remind you that we talked about the complications today. So this ICCN, the International Conference on Complications in Neurosurgery, for the fourth time will be held in March from 10 to 12. It's organized by Dr. Keki Turel. This time it's going to be again in Mumbai. The venue is JW Marriott. So hope to see you there as well. So just to remind you, because it's actually a wonderful experience I had. I have been there in 2018, 2017, where it held in for the first time. So it was a nice experience where neurosurgeons from all over the world get together to talk on the complications, because most of the time we don't talk about complications, because most of the time we come up with the good cases, the better cases, but we not to talk about complications. But complications are the best teacher, as Sachin said. So we can learn a lot from our complications. So it will make you a better surgeon, confident surgeon. So complications are very important to identify and to rectify the mistakes. Right. So John, thank you very much giving us the opportunity. So hope to see you in 2 weeks' time.
Yes, I'd just like to say, let me just get you off the screen there. Just shut the screen share. Yeah, this is An excellent way for interaction. There was some interaction. That's a valuable part of these webcasts. And I appreciate your time and participation. And yes, before we leave, I want to see if Ahmad, do you want to say hello from Afghanistan? He's a frequent visitor here, and I want to make sure. Ahmad, can you say hello? Sometimes the doc puts it on, and they'll be on duty, and they'll put it on, but we surely appreciate the dedication. Okay, gentlemen, thank you very much.